Okay. Today we have Cathy Howells talking on the topic of optimizing outcomes with RHEO knee. This is the last topic in the optimizing outcomes series for the year, unless we have any more topics coming up that we know of. We will be making a recording of this webinar, and again it will be available on the Össur website along with the PDF also of Cathy's presentation. If you do have any questions throughout the webinar, please chat them through in the notes box. They are found on the very bottom left of the screen there. There's a chat icon and a notepad icon. Whichever one you prefer to use is fine. And we'll actually go ahead and read out the questions at the very end. Okay, now that we're about to start, I have muted everyone's line, so please do chat through if you need any troubleshooting or anything else like that, if the screen freezes or any of those fun things. If you are sitting in with anyone, please also chat their names through. Of course, we only have the names of those people that have registered and have joined. So if you are sitting in the room with someone, please chat their names through so that we can submit their names to AEOPA for the CPD credits. Okay, that's all the housekeeping, so I will hand you over to Cathy. Thank you.
Thanks a lot, Irene, and welcome to Friday morning webinar, everybody. And this morning we're going to talk about the training considerations for improving performance with RHEO Knee XC and RHEO Knee XC. My screen's not going forward, Irene. Oh, thank you. So firstly, the benefits of the RHEO Knee are that it offers weight-activated stability during prosthetic stance. It will accommodate to changes in walking velocity. It offers a smooth transition between the phases of gait, between swing and stance phase of the prosthesis, and it has the potential, when used with the ProFlex and training, to decrease stresses on the remaining limb, which everyone would agree is very important for our amputee clients. Gait is optimised with RHEO by reaching the full toe-off position at the end of range of full hip extension, as we can see in the diagram on the right-hand side. The hip is extended fully at the end of stance so that the prosthetic toe can be reached. The full-length toe lever results in a longer stance phase, which then initiates an extension moment at the knee, resulting in a smooth transition from stance to swing phase. So it's an important point for the clients to get onto the toe so that they can easily disengage stance phase and commence prosthetic swing. Combined with a flex foot, there's a smoother transition onto the intact leg, decreasing the stresses on the remaining limb. Due to this long toe lever, the weight of the client is rather placed onto the sound limb rather than plopping down from a great height with a reduced step length, and it results in a more symmetrical gait. Stability on the RHEO knee is optimised by effective weight bearing, lateral pelvic shift, and controlling the location of the weight bearing along the length of the foot. So we can see in this video, and we'll start playing it again so you can see it, when Fabian starts to bear weight down through the prosthesis, initially his weight is being transferred down through the toe of the foot, and the knee is actually unstable. The knee starts to translate forwards in space, but when he puts the weight down through the RHEO through the heel of the prosthetic foot, the RHEO then becomes very stable with weight bearing, and then he can stabilise his position by pelvic and core stability so that he can be held up and then do his exercise on top of a stable bent knee. And this is a great advantage for our RHEO clients who want to take their RHEO XC into the gymnasium. It gives them a much greater variety of functional exercises that they can perform. Training considerations to optimise performance means that we need to achieve toe off, we need to achieve effective weight bearing, we need to improve our lateral pelvic shift, and then for the RHEO XC, we need to trigger the additional functionality modes, such as cycling, stair ascent, and running. and we'll be going through all of these issues in detail in the webinar this morning. The most important element of weight bearing on a prosthesis is something that I think we all need to demonstrate to ourselves. So we're going to do a little experiment this morning. If you can just stand up on the spot, place your hands on your iliac crests. Now in a moment I'm going to ask you to stand on your left leg, but don't allow your pelvis to move to the left. So your hands are gauging what your pelvis is doing. So try to stand on your left leg without moving your pelvis. And I can see Irene's pelvis immediately move to the left as she lifts her right foot. So if you try not to do that, how can you achieve standing on one leg? Have a seat, everybody. The answer is not removing your clothes, but actually by shifting your shoulders to the left-hand side or to the weight-bearing side, as we can see in the diagram here. If you want to stand on one leg and you don't shift your pelvis across or over that leg, you will do it by moving your shoulders. And this is what we call lateral trunk bending in an amputee gait. And it's probably one of the most common gait deviations that we see. And here Fabian is faking that for you. And it results because the weight is transferred using the shoulder girdle and not the pelvis during prosthetic stance phase. So I think that demonstrates to you the importance of achieving adequate lateral pelvic shift over the prosthesis. Causes of lateral trunk bending can be due to either weight-bearing issues or lateral pelvic shift issues. And here I've summarised the causes of lateral trunk bending. On the left-hand side, the weight-bearing problems. The reasons in red denote amputee-related causes. The ones in grey are more the prosthetic causes, and today we're dealing with the red causes. Weight-bearing problems could be that your client is a primary user, and so they're not used to bearing weight on a prosthesis, and they don't know how to shift their weight onto the prosthesis, or moving the weight towards the prosthesis is a little uncomfortable, which is normal when someone first starts wearing a prosthesis, as I'm sure you're all aware. On the right-hand side, we can see problems that occur with lateral pelvic shift. The client may have quite a short or flabby stump, which means that the abductors can be weak or impaired in their functioning. They may have poor balance and poor core stability and not be able to hold their weight over the prosthetic side. Or they may have a lack of upper body rotation so that they can't balance themselves over the prosthesis when they're standing on one leg. Or they may have an abduction contracture which also contributes to this problem. And we'll look at how these things actually work. In normal gait, control of lateral pelvic shift is done by the gluteus medius muscle. You can see the number 2 there on the diagram. The glute med on the weight-bearing side contracts eccentrically to hold the pelvis stable and level. During stance phase, the pelvis will drop slightly or tilt downwards on the swing side, but it's the glute med acting to hold the pelvis in a stable position. So glute med strength and control is key. Rotation of the upper body in opposition to the pelvis is also important for balancing the weight over the stance limb, as is core stability in keeping the trunk erect over the stance phase limb. In normal gait, the pelvis tracks laterally towards the weight-bearing side and creates a sinusoidal S-curve, as we can see here in the diagram. Lateral pelvic shift will reach its maximum just after mid-stance on the stance leg. In the case of above-knee amputation, the effectiveness of the glute medius muscle is decreased. Obviously, there's a destabilisation of the lever's contact with the ground due to the femur being cut and now encased in a socket. We have the motion of the femoral remnant within the socket, causing destability of that side. There may be a weakness of the glute med due to disuse, in the amputee not being mobile prior to amputation, and then in the healing phase after surgery prior to prosthetic fitting. And there may be a decrease of core and abdominal strength and control on the affected side due to a decrease in weight of the limb. The effectiveness of the glute med muscle can also be due to sectioning of the adductors, in that when the adductors are sectioned, the glute med can pull the stump into abduction and result in an abduction contracture, because the abductors may become shortened and overactive, and therefore you'll have a difficulty in achieving the lengthened position of the abductors to achieve adequate socket adduction in the prosthesis. Other factors contributing to shortening of the abductors will include positioning, so constant positioning in the sitting position with the hip inflection and abduction, and a habit pattern in keeping the stump elevated and resting on surfaces during mobilisation and before prosthetic fitting. Now, in stance phase, for maximal effectiveness, the abductors need to be lengthened by adduction of the femoral remnant, as you would well know. So in the diagram, and on letter A in the diagram, we have it with the stump with no added adduction in the socket, and therefore the glute med min will not be lengthened to its position of mechanical advantage. In number B, you will see that the socket is adding a deduction to the femoral remnant, so that effectively the glute med min is lengthened and able to work in its most effective position. It then works eccentrically during weight bearing on a well-stabilised femoral remnant, which should be uninhibited by pain. When we're considering initial gait training, weight transference is dependent on lateral pelvic shift, as we saw with our little experiment early this morning. So we need to move that pelvis laterally over the prosthesis. To avoid lateral trunk bending, effective training needs to occur in these initial stages. Now, if we look at the picture on the left, you can see that by using contralateral hand support to the prosthesis, weight is taken away from the prosthesis, and it's unlikely that the pelvis will be allowed to travel laterally over the prosthesis during prosthetic stance phase. If we look at the diagram on the right-hand side, you can see that the client using ipsilateral hand support is able to move the pelvis over the prosthesis and put weight down through the prosthesis. The other reason that this is important is that the length of the arrow in those diagrams represents the amount of relief that you are giving the glute med muscles on the affected side during stance. So you can see if your hand support is contralateral to the prosthesis, that muscle will be getting a large amount of help to stabilise the person over their prosthesis. Whereas if the weight is going through the same side hand, that muscle is not getting as much help, and therefore will be able to become stronger and is more likely to be able to support the weight over the prosthesis towards hands-free walking. This carries on to use of an aid, and use of walking aids has a great influence on amputee gait. Same thing with the bars. The stick in the opposite hand discourages weight bearing and discourages lateral pelvic shift to the side of the prosthesis. Whereas if you put the stick in the same side as the prosthesis, you will be encouraging weight transference and thus lateral pelvic shift to the prosthetic side. And this is what we're looking for, as a reminder, to avoid lateral trunk bending during amputee gait. The use of aids can also cause a flex gait pattern in early training if we're not placing the sticks correctly. Stick placement too anterior to the foot will result in difficulty extending the hip on the prosthetic side, and difficulty reaching the prosthetic toe. In the picture on the right, you can see that the aids are placed correctly. They are at the level of the prosthetic toe on the prosthetic foot during prosthetic stance phase. And you can see that the hip on the prosthetic side is extended nicely, the trunk is erect, and at the end of prosthetic stance phase, he is able to get his weight onto the prosthetic toe. Remember, this is important for disengaging the prosthetic knee joint. Now here we've got a video where we can see the consequences of not achieving proper toe off. On the step here, you can see that the toe catches. So if we don't achieve the end of stance phase, there we can see swing starts too soon. There's a shortened stride with the sound limb. He's using a shortened toe lever because he's not getting to the end of the foot. So he has difficulty initiating prosthetic swing, and he's more than likely to catch the prosthetic foot on the floor and fall. You can see it right there, his last step. So a very important point there, especially for your NPK joints and total knees as well. Getting right onto the prosthetic toe is important to disengage the knee, then your hip is nice and high to swing through swing phase and clear the toe. Falls and lack of confidence in early gait training occur when the prosthesis is used as a strut and not a leg. And I think when they're using the prosthesis as a strut, the prosthesis is often placed in a place where alignment is not in a safe position. The prosthesis is generally unloaded so that the knee is more likely to flex. Knee joints will be forced into flexion, and there will be excessive rotation forces around the stump. When the prosthesis is used as a leg and kept in the correct alignment, the inherent alignment stability of the prosthesis is maximised. Constant reminders are needed to reinforce their safe technique. The client should be stepping around on the prosthesis, never spinning on the prosthesis. The prosthetic foot is kept underneath the hip, and the prosthesis must be loaded correctly. So you can see a lot of weight there going down through the heel of the prosthesis so that when they're wearing their NPK RHEO knee joint, the stance phase resistance will be there to support the amputee during sitting. Strategies that I often use for increasing weight bearing on the prosthesis will include things like the use of scales and seeing what their initial weight is and how much weight they can body weight they can transfer onto the prosthesis. That's a form of biofeedback. You can also use biofeedback machines where the sound increases as weight increases towards the prosthesis. I do a lot of weight transference exercises with visual feedback using mirrors so that the patient can see the movement of their pelvis and the alignment of their upper body and everything coming into line, shoulder over hip over foot on the prosthesis, and effective weight bearing that way. We can decrease the contralateral hand support, and we can add resistance to the activity, as you can see in this slide. So we've got a TheraBand around the pelvis, resisting the lateral tracking of the pelvis over the prosthesis, and so strengthening that glute med in stabilising the pelvis over the prosthesis. Weight transference can also be improved by adductor strengthening. Remember, the adductors have to be strong to hold the pelvis and avoid that excessive dipping that occurs through sound limb swing phase. So in the picture on the left-hand side, we've just got the TheraBand strengthening exercise. The muscle will be strengthened in a concentric contraction as he abducts to the side, and it will be being strengthened in an eccentric contraction as he controls the tracking of the prosthesis back in towards the sound limb. In the video on the right-hand side, we can add resistance to the walking exercise, And your client will undoubtedly report when you do this that they're putting much more weight down through the prosthesis and pulling down and back into their socket to walk with much more purpose, and they will swing their arms as well to get more power out of their hip on the prosthetic side, out of the extensors of the hip, and they'll actually walk much more strongly and more effectively. It's a really good exercise to demonstrate how they should be pushing through that prosthesis with every step that they take. Gaining confidence in that weight-activated resistance is very important because walking with a prosthesis is a confidence game. So we spend a lot of time testing your knee in initial training, so just in between the bars, noticing that the more weight you place on the prosthesis, the more it will hold you up. Then on the right-hand side, we do a lot of exercises, strengthening the core and the hip muscles, the stability of those muscles on the loaded RHEO. That's all right, there we can see there. So his weight bearing down through the flexed RHEO and the resistance is holding him up nicely. He's holding his core in, his lumbar spine is extended, his glute is working strongly there, both glutes, the glute max and the glute med min, to hold him and hold him weight bearing on that RHEO so that he can then perform a rowing exercise. Safety provided with the RHEO is really significant in sitting to standing activities, and so I do a lot of sitting and squatting drills with the RHEO clients. Emphasis is on weight bearing through the heel of the prosthesis again. You can see here he's lifting a medicine ball up off the chair. He's going to place that over his head, and then he's going to squat back down and put the ball down onto the chair. So it's a very functional exercise in teaching the client how to lift loads properly so that safety is provided for their back. They will need to use core stability and gluteal activation to maintain the extended lumbar spine and pelvic position, and it ensures that the prosthetic knee does not translate forward in space. Remembering, if the knee translates forward in space, they'll be moving their weight towards the prosthetic toe, and the knee will start to flex. We also look at stepping over objects, and in this way we need to disengage the RHEO, step over an object, and place the foot on the floor on the other side. Now notice when he places the foot on the other side of the object, the knee is in flexion, but the RHEO offers him that stance phase resistance so he can transfer his weight onto it as long as weight goes down through the heel of the prosthetic foot, and then he extends his stump over the top and walks over the object. Tricky one, but worth it in the training. It also means that the client is getting confidence that they can weight bear onto a flexed knee as long as they control where they're putting their weight on the prosthetic foot. Then in the second video, we can see training to assist on slopes and uneven terrain and gain confidence in the fact that the knee can be flexing underneath them with resistance, and they will have time to regain their balance by moving the sound limb. So he's on a wobbly surface there of foam, walking sideways as he weight bears. The foot goes down into plantar flexion, the knee flexes, but keeping load on the prosthesis means that the stance phase resistance is engaged, and he has plenty of time to move his sound limb and regain his balance. And essentially that's what we're doing when we walk down slopes or on uneven terrain. Now we talked about amputation decreasing the ability to stabilise the pelvis in the mediolateral plane. It also decreases the ability to stabilise the pelvis in the AP plane. So after transfemoral amputation, you can see on the left, pre-amputation, the pelvis can be held level by the interaction of the abdominals and the hamstring muscles. On the right-hand side, when the hamstring muscles have been sectioned and weight bearing is occurring on the prosthetic side, there's a decreased pull by the hamstrings, which means that the pelvis will rotate anteriorly, tipping the pelvis in that anterior position. The iliopsoas will be strengthened because our extensors are not working as well as they were before, because again the hamstrings have been cut, and also the hip extensors are often weakened because they've been kept in that lengthened position for a long time. Because the client has been inactive, there will be a weakening of the abdominal muscles, again, so they won't be pulling the pelvis posteriorly, they'll be letting the abdominal sag, so the anterior tilt will happen, and the erector spinae will be pulling up into extension of the lumbar spine as well, increasing the tilt, the anterior tilt of the pelvis. So that decrease in core stability in the transfemoral gait predisposes to anterior pelvic tilt and increases our flexion of the hip on that side. Decrease stabilisation by the hamstrings, over-tight psoas, weakened and lengthened abdominals, an imbalance occurring between the strength of the abdominal musculature and the flexors and extensors of the hip has very important consequences for transfemoral gait, as we can see on the right-hand side described here. There'll be a decreased push-off by the hip extensors, a shortened intact leg step length. Therefore, there'll be difficulty initiating and clearing the prosthesis during swing phase. This may lead to the client wanting you to shorten their prosthesis, predisposing to other gait deviations and problems, perhaps falling over and catching the toe. And there'll also be impaired momentum and loss of power coming off the prosthesis. This was demonstrated in a study by Ignacio Gennard and Bob Gailey in 2011 when they looked at a number of transfemoral amputees. Those who were able to maintain an equal length with their prosthesis only had a slight degree of hip flexor tightness on the prosthetic side, whereas those who had a shortened prosthetic limb had a greater degree of hip flexor tightness. So they were obviously not able to get through to the prosthetic toe, had that shortened step and difficulty in clearing the prosthesis, and so the prosthesis was shortened for them to assist in clearing. Problems also occur if you have increased posterior rotation of the pelvis at the end of stance phase, which you will if you have a decrease in strength of the abdominals on that side and also a weakening of the glutes on the prosthetic side. You'll have that weakened end of prosthetic stance. The client won't be able to push off their prosthetic toe. In fact, they may actively externally rotate their hip and thus externally rotate their foot so that they avoid the nice long toe lever provided by a flex foot. And so they'll have impaired momentum and impaired prosthetic swing that way as well. So we need to look at restoring the balance of rotation, which happens normally during gait. In normal gait, the shoulder girdle and the pelvis rotate in opposition to help balance the body over the stance limb. And we can see on the right-hand side doing a facilitated walking drill. As the pelvis rotates during prosthetic stance, I'm going to rotate the shoulders in opposition to help balance the client over the prosthesis. And I find that this is a very effective technique for getting rid of aids, walking aids altogether. We look at reinforcing upper body rotation during gait. We can pop a couple of little hand weights in the hands and get the client swinging their arms. And then tougher exercises on the right using the stance phase resistance from the RHEO, MPKs, and resisting upper body rotation. Core strengthening is very important for all amputees, and so using the RHEO we can utilise the extension lock in their gym program, so we can get them doing planking off the toes, and then we can also get them doing push-ups off the toes for our high-end users. Very important for those, especially those wearing the RHEO KNEE XC, as you can see here in the slides, for those who might be moving on to higher impact activities, higher sporting activities, and perhaps even leg-over-leg running. Looking at resisted walking drills, we can also resist lateral pelvic shift itself, not just walking. So by adding the resistance to the side, they have to pull harder with their pelvis to get the pelvis over the prosthesis during gait. You can see that as he walks towards us. He's really got to push down and back through the prosthesis and also bring the pelvis to the side of the prosthesis so that his lateral trunk bending can be minimised. And so he's not laterally trunk bending, he's going to be using his arm swing and upper body rotation instead of lateral trunk bending. Now on the right hand side we can see resisted walking drills in the backwards direction, because this is another good one for increasing confidence in the stance phase resistance of the RHEO as he pushes into flexion to walk backwards and getting a powerful backwards walk. I might just have a look at that again. So he can walk backwards very effectively. He'll be able to pull loads backwards by pushing into that flexion resistance as he walks backwards. And he's really quite stable on that knee, so he's going to get a lot of confidence in it. When I'm looking at training RHEO on stairs, I always train downstairs first because that's a matter of safety rather than the walking upstairs mode. In walking downstairs, the prosthesis needs to be loaded optimally. So when you're doing your initial training, use the rail on the prosthetic side. There should be no extension of the stump on heel strike on the step below. And foot placement is very important. Only the last third or the last third of the prosthetic foot stays on the step, and more of the foot can be left on the step if you're combining the RHEO with the ProFlex because of the increased amount of dorsiflexion that is available with the ProFlex range. And then if you've had your heart medication for the morning, you can do it on moving stairs, down escalators, if you've got someone who's quite impatient to get down the stairs. So looking at initiating stairs in walking up the stairs, we need to trigger the RHEO into stair mode, and that's done by slightly extending the hip and then flexing it rapidly. So we swipe the floor backwards and then flex the hip quickly, and that will allow the RHEO to enter stair mode. The RHEO can then be placed on the foot can be placed on the step above the sound limb. Once the foot is placed on the step above, you need to put the weight down through the prosthesis through the heel to then translate the weight onto the prosthesis and allow stepping up over with the sound limb. A good tip is to begin with the sound limb on the step above the stairs, and we'll see that here because it makes it easier for the client to trigger stair mode of the RHEO XC. So you can see that swiping motion backwards followed by rapid flexion of the hip on the prosthetic side allows him to place the prosthetic foot on the step above him. Weight goes down through the RHEO, and the knee is not allowed to translate forwards in space as he's walking up. As he's walking down, the back third of the foot is kept on the step. We'll have a look at that again. So progressing up the stairs, not allowing the knee to translate forwards once the prosthetic foot has been placed on the step above. If that happens, the knee will keep flexing and it won't be stable enough for weight bearing. Okay, so we're utilising the stance phase resistance nicely to walk up, down, Posterior third of the foot stays on the step. Prosthesis is loaded maximally, so using the bar on the prosthetic side. And he walks down really quite nicely there. Once you reach the top of the stairs, if the prosthetic foot has reached the top of the stairs first, just extend the residual limb over the prosthesis and keep walking to exit stair mode of RHEO. If your sound limb reaches the top of the stairs first, you just have to wait for a split second with the RHEO extended so that it knows there's not another stair above and it won't keep flexing, and then you continue walking. So sound side, if it gets to the top of the stairs first, wait for a split second before you walk off so that the RHEO knows to exit stair mode and continue walking. Another look at someone who's a little more experienced at stair ascent. And really you can see that the swiping motion backwards has been refined quite nicely. Just a tip for initial training, never stand directly behind the person you're training because sometimes they can be quite enthusiastic in extending. The foot will fly up and you could lose a couple of front teeth. So always stand to the side. Notice that there is no translation of the knee forwards in space once he's putting weight onto the RHEO ascending the stairs. Very important point there. Training on slopes, we need to avoid overstepping with the RHEO down the slope, because if you overstep, you are likely to then produce an extension movement with the stump, which we don't want. We actually want the stump to continue into hip flexion while the prosthesis is loaded, so we can use maximal stance phase resistance as he's walking down the slope there. Maintain an erect trunk so that the weight falls behind the RHEO and it continues into flexion. Use the rail on the same side, again, so we're getting maximal weight onto the RHEO, and the more weight you get onto the RHEO, the more safe they will feel weight bearing on a flexing knee joint. There we go. Someone a little more experienced down slopes with the RHEO, really loading the RHEO as hard as possible and allowing it to flex. So not producing an extension movement at the stump, you just ride it down. In fact, you can even get the client to push into it, into stump flexion, to get them weight bearing. There we go, walking down a grassy slope, and then just walking off at the end, and the RHEO will function normally in normal walking. Now, if we're looking at the RHEO XC, we can use the cycling mode for aerobic exercise. Seat height is important. We don't want the RHEO to be fully extended at the bottom of the prosthetic cycle. So we don't want the RHEO to be fully extended when the prosthesis comes to the bottom of the cycling mode. To enter cycling mode, we just need 2 rotations with minimal load on the knee. You'll hear 1 long beep and the prosthesis will be in cycling mode. And during cycling mode, there is no resistance to the knee motion. So if they were to get off and walk, there would be no stance phase resistance. So you just then pedal in cycling mode. When you want to get off the bike and exit cycling mode, just let the knee extend beyond 15 degrees. So between 15 degrees and 0 degrees, you'll hear 1 short beep and you'll be out of cycling mode. You'll be able to walk off safely on the RHEO and your stance phase resistance will be reinstated. Hop, skip, running is one thing that I do with a lot of my high-end clients. It's a really good way of moving quickly without using step-over-step running. And you can see hop-skip running then means that you do a double hop on the sound limb, and that will give the prosthesis time to swing through. If you pump strongly with the arms, it will also help in progression of the weight over the prosthesis quickly. And this can be a good manoeuvre to do running for the bus, playing soccer with your kids in the backyard, without actually having to go through step-over-step running, which is much harder and also causes much more stress through the stump and lumbar spine of the amputee. However, a lot of our clients are utilising the RHEO XC will want to learn how to run and use that mode. Running mode is triggered automatically when a stance phase of less than 1/3 of a second is detected by the RHEO. So it'll detect that faster movement and a decreased stance phase time. During running, the stair ascent step over to step mode is blocked, so they won't be running upstairs, and let's face it, who wants to do that anyway? So we're just running on the flat. That's important to know. And that's been tested at speeds up to 12.6 kilometres an hour, which is really quite a smart pace. So we can get up to quite a quick speed over short distances on the RHEO. I do reinforce to my transfemoral clients that they're not going to be using this for aerobic training, because you're not going to be able to run like this step over step for 30 to 40 minutes continually. Preparation of your amputee athlete or amputee client is key. If they're going to start to learn how to run, they need a very strong core, they need a very strong hip on that prosthetic side, and I always begin with sideways flight drills to get them used to the impact, which is much increased during running as opposed to walking, because as you can see, running involves that flight phase when we've got both feet off the ground at the same time, and there's much more impact in going from foot to foot, especially down through the prosthesis. That's all I've got on specific RHEO 3 and RHEO XC training considerations this morning, but we're going to stay online so you can chat through some questions to us or comments, and we'll talk about those if you've got any. Thanks a lot.
Thanks, Cathy. Irene again, everyone. Please do stick around if you have any questions. I have put everyone on mute just to avoid audio issues, but if you do have